Thank you for the invitation to talk today, and I really appreciate being here. And I'm going to talk on bringing AI and breast cancer imaging from the bench to the bedside, and I appreciated the introductions because we develop these methods by sitting with radiologists who are working with the patients to figure out where the need is. So I appreciate the bedside to bench also. I need to acknowledge my grants and conflicts of interest, and part of these have been mentioned by Jeff, and I will move on. They're up there long enough. Okay. And I also want to acknowledge, so we don't forget them at the end, my lab. Everything is a team effort. I have a lot of brilliant people in my lab. And we discover new ways to use computers to enrich the information extracted from medical images so that radiologists can better find, diagnose, and understand disease. So today on AI and breast cancer imaging from bench to bedside, a few notes. First, most of the focus of my work is on using images that are clinically and routinely obtained on the population. And while I do have some work where I collaborate with folks who are developing a new imaging system and we connect the AI with it, today and for most of my work it's clinically and routinely. And what we aim to do is to ask questions about the relationships between features seen in medical images and the biology of cancer so that eventually we can detect and diagnose disease early and to give the right patient the right treatment at the right time. And I've added this statement because in the recent years, AI has also grown to improve the efficiency and the workflow in medical imaging interpretations. This talk is focused on the translation from bench to bedside. So I just want to set this straight up in the beginning. What I do, scientific research creates new knowledge. However, translation to the public often requires collaboration with industry. And we've gone through that route a couple times, as I'll show you, keeping on track with the focus of this conference, is we have the idea by multidisciplinary teams. We investigate in the lab, we might do proof of concept, maybe a local reader study, and then we want to translate it. We might do a startup or work with a bigger company. We get an FDA product, it's installed, and it goes into clinical use. What I find is that many of us, including me, get very excited here. And we ask the question, why isn't it here in clinical use right away? And there is a long but defined route to get it there, but it takes a lot of time and patience. So very, very quickly, let's start. What is AI? I know this audience is a combination of engineering and medicine, so I've tried to touch on both. But I won't take long here. Basically with AI, we're looking at computer systems to perform tasks that usually require human intelligence. Wrong way. And part of AI is machine learning, which is AI that includes systems that can learn from data, identify patterns, makes decisions. And within machine learning, there's deep learning, which is a type of machine learning based on learning data representations. We're not going to go, this is not a tutorial on that, but I put this slide here because a lot of the work we do is in transfer learning, not learning from scratch deep learning. And I put this up there because there's a major effort and need to get data that is well curated, has good annotations, covers the spectrum of disease, and until we get there, transfer learning, either fine-tuning or by feature extraction, has been doing quite well. So I'm going to go through these various aspects of AI in breast cancer detection, diagnosis, and therapy, and end with some challenges in the future. I'm going to start with detection, CADE. I started in this field almost 30 years ago where we called it computer-aided, and now it's AI-aided, where ultimately the decision for many of these will be still made by the clinician being aided by output from a computer. And in computer-aided detection, does everyone here know about Waldo, right? The Where's Waldo books? You're able, In computer-aided detection, the computer is looking for something with red and white stripes. That's it. So the same thing here. The computer is looking to maybe find this cancer at an earlier time when it might not have been noticed. It's not doing magic, it's looking for something that can be seen. Of course, would the clinician act on it is up to the clinician. So we did a lot of work, and actually computer-aided detection is something that's been translated for over a decade. This is our 1994 prototype system for detection of mass lesions and cluster microcalcifications. This was film. Some of you might remember film. We had to digitize it, and it was stored, analyzed by a big computer, and printed out. We did not need high-quality printing. We just needed someone to point out saying, maybe this is where the lesion is. We're trying to find Waldo. We're not classifying Waldo yet, just trying to find him. And I put this in my talk because in '94 we published what we believe is the first convolutional neural network paper on using CNNs in medical image interpretation. We did not call it convolutional neural network. We did not call it deep learning. We called it shift invariant artificial neural network. And it's not as deep. It was a bit shallow, but basically the same mechanism to find microcalcifications, malignant or benign, in breast mammograms. So in screening mammograms, the prevalence of cancer, maybe every 1,000 mammograms being read, there's maybe only 5 that are going to be seen. So there's a big problem of potential oversight. You can see it. So in computer-aided detection, it's as if you went to the refrigerator and opened the door to find the ketchup, and you're like, where is it? And your roommate says it's right there in front of your nose. That's what computer-aided detection was developed to be. And currently, over 90% of screening mammograms in the U.S. will have some kind of computer read. However, the final decision is still made by the radiologist. And this is how it's been for a long time. However, there's a change now. It's a change from a second reader to a concurrent reader. So in the computer-aided detection for screening mammograms, the way to read it is the radiologist would look at the image, find the cancers, and when they felt they were done, press the button, and the computer would show. That's as a second reader. It was not made to be a primary reader. However, now developments are on where the computer is moving from being a second reader to a concurrent reader. The radiologist sits down to read the image, presses the button at the same time, and they work together. This has been found to improve efficiency, especially when 3D imaging is being used for screening. A lot more data to look at. Some examples of that is in automatic whole breast ultrasound. Roughly half the women who are getting screening mammograms will have a dense breast, and the mammogram is limited there. So they will go on to have either potentially an adjunct screening ultrasound or MRI. And here, this is not a comprehensive lecture. I've tried to give you the flavor of the changes that are going on in AI and imaging. So here, the computer is helping locate lesions in 3D breast ultrasound. And they've shown that you can reduce the time of interpretation while maintaining diagnostic accuracy. Another example is in breast tomosynthesis, where using the computer as a concurrent reader, still AI aided, showed improvement in accuracy and efficiency. But even more, the computer is now moving to become an independent reader. So second reader, concurrent reader to independent reader. And here it may have a role in triaging. This is a simulation study, but basically these authors compared the radiologists reading on their own versus if they read but had a deep learning model that would send 20% of their patients to just come back next time for screening with no human oversight. And that's basically CADT, or role in screening, improve the efficiency, so these 20% would not even be looked at by a radiologist. There, the computer is an independent, a primary reader for those. So now in reading Waldo, you found everything with red and white stripes. Is it a bucket or is it Waldo? And that's computer-aided diagnosis. It's not a localization task anymore, it's a classification task. And in breast cancer, in the workup of lesions, the radiologist is focused on trying to estimate, is it potentially cancer or not? They don't really make a benign versus malignant decision, they make a patient management decision. But could the computer help and characterize and potentially indicate a computer-determined probability of malignancy? Again, leaving the final decision on patient management to the radiologist. On the left, we have a benign. The right is a malignant. The middle one, very difficult. It actually is a malignant. Could the computer help in classifying that? Now, in diagnostic breast imaging, it's difficult because the radiologist, and this is Dr. Gillian Newstead, sometimes she's spinning around, she has multiple modalities to look at. So there is data overload, and the computer could help diagnose, integrate, and give it as an aid. And we've looked at these in both using human-engineered methods as well as deep learning, always focused on the specific clinical question. We start with our clinical images. This is a conventional breast MRI image. We then subject it to our methods developed for tumor segmentation and feature extraction. This here is our extracted tumor. This takes a few seconds. You can think of this as a virtual biopsy, automatic, 3D, non-invasive, covers complete tumor, and repeatable. Time you image, you can do it. Once we've extracted that, we can extract out various characteristics, size, shape, morphology of the tumor, as well as methods based on, this is dynamic contrast enhanced MRI. We're injecting contrast agent and we're looking at the uptake and the washout. Basically, in each voxel in this tumor in 3D, we can look at the uptake. This is basically if you looked at one voxel and looked at the intensity over time. Because the cancer undergoes the angiogenesis and there's more uptake of in the flow, the contrast will be uptake, and so you can see it uptake and wash out. So these are characteristics, lines of that, whereas these aren't. And so we can use that to find the most enhancing characteristics within the tumor, those that are most enhancing, and those look more malignant. And we can feed those into a classifier. We've also looked at convolutional neural networks to do this using transfer learning. We do that because no lesion segmentation is required. There's no extraction of features. We just give the computer the image. Now, we do transfer learning because we take an initial network trained on cats and dogs and light poles and extract features which then undergo classification. And we've been able to cut down the number of cases necessary. So a big thing that I'm very curious about is the hype is on deep learning, but let's not forget about all the analytical human-engineered derived methods. So we continue to look at both in all our methods. This here is showing the likelihood of cancer as deemed by our human-engineered methods. This axis is the likelihood of being cancer as determined from our deep learning methods. In a perfect world, green, which are all the non-cancer cases, would be at 0, 0, and all the cancer cases, which are shown by the red dots, would be up here at 1. Well, they're not. Neither one is doing it perfectly. If these two agreed, they would all be along the diagonal, and they're not. But what we found is by combining both of them, we can do better. You'll note that in some cases, the deep learning method is doing better, and in other cases, the human engineered is doing better. So we looked at that across a variety of breast imaging modalities, digital mammography, ultrasound, and MRI, and found that the human engineered and deep learning performed about the same, but they were looking at things differently, almost like two radiologists, right? And when we combined them, we did statistically better. So we're continuing down that path. Now, one of the things that I always tell the students in my lab when they're trying to develop deep learning is I say, think like a human. And a human tries to interpret an image and will go after the image that looks good. Now, while we could have more and more cases, what about more effective input? And so what we look at is, we know garbage in, garbage out, but there's useful images to go into the network as well as not so useful. And using how the human thinks is actually a good way of looking at that. And what we found here is we looked at the maximum intensity profile images. So basically with breast MRI, you could look, and these are dynamic, you can look at the second post-contrast, and you can see the tumor there. That gives you good 2D information. You could then subtract from that, the image without any contrast, and you can get some temporal information. And you can also do a maximum intensity profile where you're also putting into that image volume information. This is how many radiologists will first look at a breast MRI to find that image. And so we input those into the deep learning, and sure enough, the maximum intensity projection input to the neural network is statistically better. What this tells us is we don't have millions and millions of cases like other non-medical tasks. So let's be clever in picking what we input. Okay, once you have all this, you have to translate it. You need a efficient and effective human-computer interface, and that's what we have here. This is what we've been using. You click on the tumor, it segments it, it outputs a variety of features. It gives you a potential probability of malignancy relative to cases in your training set. In my lab, red is always cancer, green is always benign, no matter what we do. So, how are we doing? Okay. So to translate now from bench to bedside, we have a lot of things to do, including getting it out there so it can go through FDA so it could be used. We looked at mathematical techniques, we developed methods, we did robustness assessment, we validated, we did reader studies, and then we commercialized through company startups. In doing this, not only did we look at the computer performance, we had to look at how well do radiologists perform on their own and when they're using the aid, because this is AI-aided, computer-aided, and that difference is more important even than just the computer itself. So, because this is a bench to bedside, I'm showing you an example of how we did it. We translated this through UChicago Tech, through a venture challenge we participated in. We ended up starting a company. We went through FDA using a reader study to show proof of safety and effectiveness. And what we showed is that all radiologists, when they use this aid in characterizing lesions on breast MRI, improved, and that the ROC analysis showed that they were all their performance was statistically better than when they just used their common tools. So that's the system, and this is the one Jeff mentioned that we got the de novo clearance in 2017, and it's now under a different name. But it was a long time. This was from 2010 till now. I think now the recipe's there for FDA. Things can move a lot quicker. And it is. There's similar systems coming out for breast ultrasound. Here, this one aligns a machine learning generated probability of malignancy with an appropriate BI-RADS category, which gives information that radiologists use in making their decision on patient management. So the computer is getting closer and closer to aiding, not just in characterizing the lesion, but in making an output that is related to likelihood of cancer to aid the radiologist. But with all these systems out there, we continue to collect cases. So what do? Do we retrain our system every day, every year? And how will that affect it? So we're looking at ways to simulate that. This will be presented next week at RSNA in more detail. But basically, we have cases from 2015, 2016. We use these in training to simulate continuous learning and tested them on our data set from 2017. You can see here's the first half of 2015, then all of 2015 cases, and then 2015 in the first half, and then all of 20. And what we found is, well, the system was already at a very high level, and it did significantly increase, we found, from the beginning to the end, but not by much. And when we looked at just mass lesions and non-mass lesions, it was pretty consistent too. But this is going to happen, and I think a lot of conversation has to be done on when do we retrain, and what conditions need to be met to continue using it. Next, what is the role in imaging AI in breast cancer therapy? So we've already covered finding cancer early and computer-aided detection. That was a localization task. We looked at breast cancer diagnosis. That's a characterization task. That's where the radiologist is assessing should the woman go to biopsy or not, what is the likelihood that it's cancer. And we've shown how computers could aid in both of those. And both of those now have been translated in breast cancer detection. That's been out for a while. So we continue down the path of using our human-engineered radiomics and our deep learning in trying to see, could image data be used to assess treatment response as well as risk of recurrence. And that was shown here. These are the same features that we pulled out before, but now it's a different question. So it's a different weighting, a different classifier. And what we found is this most enhancing tumor volume, those voxels that are having the uptake, do quite well in differentiating survival and not on two types of hormone status, but not so much with triple negative. So we're continuing down the path. This is a more difficult problem for the biggest reason is there's not a lot of data out there. Different places treat their patients differently. The tumor will respond for different mechanisms, and to throw that all together will be difficult. But potentially, just as we have multi-gene assays of risk recurrence, the Oncotype DX, MammaPrint, and PAM50, perhaps we also will merge with that virtual biopsies focused on tumor size, irregularity, and this heterogeneity of uptake. But how do we harness this imaging big data? We can go right to the clinical task, or we can step back and see if we can find more relationships of the imaging data to clinical data, molecular data, genomic data, and outcome data. And we did this in a collaboration with the Cancer Genome Atlas and the Cancer Imaging Archive a few years back. And once you discover, then you can develop separate or joint predictive models for the use in risk assessment, screening, detection, diagnosis, prognosis, therapeutic response, risk of recurrence, and others. So this is how it works, and I think this gives the overall picture. A woman comes in, she has screening, maybe something found, she has diagnostic imaging. If it's deemed, she goes to biopsy, she may have, and it's cancer, she'll have treatment, she'll need treatment planning, follow-up to determine treatment response, and then assessment of risk of recurrence. So at this point here, during diagnostic imaging, she may be sent to biopsy. That's where we're getting biopsy results, genetic testing. That's where we can do discovery. Now sometimes my students give talks on computer-aided diagnosis. I get the question, so you're not going to replace biopsy? And my answer is no. Now some radiologists will need that help. Some radiologists may be overcalled too much and they would benefit, or they miss cancers. So there is a role in clinical workup of, say, breast MRIs and diagnostic imaging. But we also want to use it to gather information. And let's say we find an interesting imaging signature in this relationship. Maybe we'll see that signature during screening, or maybe we'll see it when we're trying to assess risk of recurrence. So we can translate that finding into these virtual biopsies to use them when an actual biopsy is not practical. You're not going to be doing real biopsies during screening. You're not going to be doing it following response or assessing risk of recurrence. You're not going to be constantly poking, but you can repeatedly image the patient and do the virtual biopsy. So we want to learn here and then use it elsewhere. So what are some of our early results from this collaboration with NCI, the TCGA, and TCIA? Well, we found significant associations between these are the ER, PR, positive, negative patients with various radiomic features. And we found the clustering, these are our radiomic features that we've characteristics automatically extracted by the computer, relating it to the different tumor stages. And then we did data mining between the radiomic features. And people may say, I have 400 radiomic features. They don't really have 400. They have 400 mathematical descriptors and maybe 6 or 10 categories of types of features. And so it's really important to look at it that way. And what we found is we looked at these features relative to different pathways. And we found that transcriptional activities of various genetic pathways were positively associated with tumor size, blurred tumor margin, and irregular tumor shape, and that microRNA expressions were associated with the tumor radiomic phenotypes of size and enhancement texture, suggesting that microRNAs may mediate the growth of tumors and the heterogeneity of the angiogenesis in the tumor. So we're still in the discovery stage, but we can identify that tumor signature and use it elsewhere. So let's talk about challenges in the last 5 minutes. You've developed a method, and there's a lot of worries. Image acquisition. You know, if you change your acquisition system, how does the spatial resolution, noise, or system gain will change and affect your results? What about the populations differences between training and testing? They might have different disease prevalence if you're picking them from different geographical lesion areas, and the need for harmonization. I want to point out that people talk about, I need more cases, and not just cases, it's the distribution of the types of cases in your database. It has to span all types of cancers, all types of benign, all types of normal in order to train. And it needs a high quality of annotation and the truth. And we go through databases over and over to verify that. There are public databases out there, and that's great, but always verify them to make sure they're telling you, because, you know, everything has problems sometimes. One thing we're looking at is how to harmonize. So we have a large data set from the US and a large one from China, and these are the distributions of cancers between the two. And we're looking at ways to harmonize them so that our output overlaps more. These are all cancer cases shown here. One of the methods we look at is the Combac one that uses a Bayes method. Basically, we're taking care of the batch effect, similar to what they do in genomics. Here's the benign for the same set, and Heather Whitney will be presenting this next week at RSNA. And you can see now each one overlaps more. And what we found is that when we did this and we grouped everything, we did better after we harmonized the malignant altogether and the benign altogether. Okay, so now you have a system, you've worked on a human interface. Keep in mind that if radiologists do not find the interface user-friendly, the AI will not be used. I know in a research lab, you like all these, oh, I can do this, I can do this, I have these buttons here, and I have these buttons here. When it goes translated, it gets stripped down to a few buttons, it has to be quick, and you have to realize that if a case is sent to the workstation and there happens to be no image data, So the computer crashes. Whose fault is it? It's going to be your fault. It's not the fault that they didn't send data. It either works or it doesn't. So translator will take that in. Another big area is explanatory AI. And so 1 minute on this, and I know this was on breast, but we have examples on lung. We have a method, Jenny Crosby is working on finding pneumothorax in chest radiographs. And we've looked at many of the systems out there, take a whole chest radiograph, train it. Now you've probably all heard the story how when they went back and looked, the deep network wasn't really looking for pneumothorax, they were looking for chest tubes. And so they got a high score, but for the wrong reason. So we've gone back and we look at these chest radiographs at different resolution. And for those who are taking it in at the full chest and reducing it down to 256 to 256 roughly, this is the truth. This is the pneumothorax outline. The red spots are where the computer thinks there's something wrong there. And what we found is that 33% of the heat maps for cases correctly classified as having a pneumothorax were marked on the pneumothorax. That means all the other ones were being highlighted as saying this is a case with pneumothorax, but looking elsewhere. We're diving deeper into this, but explanatory AI is extremely important. And then you have to integrate it into the workflow. I'm a big believer that you need to go through FDA. You can develop methods, you can write a lot of papers, you can write a lot of grants, but until you pass through, you don't know what you're missing. So that's very important for the effectiveness and safety. And then you have an FDA product and you put it in, and the seamless integration of AI into the clinical workflow. You have to worry about cybersecurity and disaster recovery because you're putting this computer system on a clinical backbone. It's not like just putting it up there in a gaming network or something. It's a big difference. And 30 years ago, Jim Lair, who was one of the chairs of radiology back there, in the early days when we were developing detection of lung nodules and chest radiographs and lesions on mammograms, he told me a radiologist has to do a day's work in a day and not more. And that's very important. It has to fit within the workflow, and I've never forgotten what he told me. It's 30 years ago. Okay, so coming to the end, those are just tidbits of us translating our breast image analysis. You know, detection went through O2, and now it's at Hologic, and there's ICAT and all those others. Diagnosis from MRI and ultrasound is now moving along. Triage systems are moving along and getting out there. The radiologist, the clinician, is still very much in the loop. These are multidisciplinary collaborations. You can't develop AI for medicine in isolation. And it's very important to have the known clinical question. What question are you answering? Images and truth are very important, and you have to be very cautious of garbage in, garbage out. There's many systems, I believe, that will come up as secondary or concurrent reader, leaving the final decision to the radiologist. There will be some that will be now used as primary reader. And for the radiologist, I was at a perception workshop the other day, and the bulk of time that a radiologist spends is not in interpreting the image. It's in all the setup that it takes. And that's where AI will also help in organizing that workflow so they can do their job. And of course, use in cancer discovery. So a lot of work to do, and nobody's going to lose their job. As now I think everyone who gives an AI talk has to say, the radiologist using AI will replace the radiologist who doesn't. AI is not going to replace the radiologist. Thank you. Okay, I'll repeat the question. Okay, yes. So the question was, if an AI is developed on one ethnic group, how is it going to work on another ethnic group, and what are you going to do? And that's one of the things we're trying with this U.S.-China data set. We have roughly 1,000 from the U.S. and 2,000 from China. And one of the things we've done is it led us down the road to you have to go back and see how do they define their molecular subtypes, the luminal A, luminal B, and how do they vary from year to year, and then how is the acquisition system different? A big difference was in the U.S., we're at 60 seconds intervals for dynamic contrast MRI. Over there, they're 90 seconds. So that really changed which features would be chosen. So we're taking two approaches. One is, do we harmonize up front and then use a common algorithm? Or do we know that we have all these characteristics we could apply? And of course, the kinetic ones aren't going to be that useful with the China because it's 90 second. Do we let them each pick their own features? No one's going to, the computer will pick them. And then it's the same skeleton of an algorithm, but it's different. It's trained differently. So we're looking at both ways, harmonizing up front, or do you harmonize later on? But you have to take that into account because, and that's what I mean by it's not just number of cases, but the distribution of cases. We found in the US, our data set, since MR was rapidly being developed, that our set and the types of cancers varied a lot. But the 3 years of 2015, 16, and 17, and it will be in the talk next week at RSNA, it's amazing how consistent the cases are. So that will vary. And so that way you can't get rid of the physical acquisition, you can't get rid of the biology.
First of all, thank you for a great talk and showing that you can actually survive the AI winter back in the 90s, so thank you. I had a question. It has to do with using the ROC curve as a measure of goodness, yet we've known since 1964 that where you operate on the ROC curve has to do about your sense of harms versus benefits and the scenario for which you're using the technology. Have you elicited from your users their minimum sensitivities and specificities, and do you see whether or not that assessment of harms and benefits predicts adoption?
Very good question. First, I was trained by Charlie Metz, so I grew up with ROC, and ROC, an area under the ROC curve, is what the FDA is currently using as a primary endpoint metric. Secondary endpoint is sensitivity and specificity. ROC analysis does not depend on the prevalence, so that's a very useful metric to use in assessing. It also will not depend, as you noted, on where the radiologist, the clinician, is along that curve. And that's why we have the secondary endpoint of specificity and sensitivity, which are calculated, well, at least with breast imaging, for classification based on the BI-RADS. So what is specificity and sensitivity at BI-RADS 3 or 4A? And that brings it more down to how the clinician will use it. So I think it's very important to do both because of the benefits of ROC analysis being the prevalence independence and a nice overall metric, but not to forget the secondary endpoints because that's how people in the field are using it. So you have to do both.
So you made it sound easy to get this from the lab through FDA in practice. I know it wasn't. Can you say a little bit about what some of the roadblocks that you faced were and how you handled them?
Okay, well, and keep in mind, I've been doing this for 25 years, so easy would be overnight. It's not so, just, the question was some of the roadblocks. One was, in the early days, we didn't have enough data, so it wasn't like we have a data set with just cancers. We had cancers and non-cancers, and we worked on detecting anything in the image that was actionable. So it was actionable areas versus not, and now that wasn't good enough eventually. Those got to be, okay, the actionable ones, meaning the radiologist maybe would send the woman on to biopsy, which ones are cancers and which ones not. So database is extremely important. Working with clinicians, I don't think has been a roadblock. They've been very open to this because we've always presented it as a computer aid, and we don't walk in and say, oh, we're going to replace you. If you've worked a long time with clinicians, you see the bulk of their knowledge and how they handle subtle and diverse diseases. So one thing was the correct database, just getting cases. I tell students who come to my lab, they have a great sandbox. I have a lot of cases, they've been extremely vetted, very careful, even public data sets that we download, we go through. But it's a lot of work. That's not easy, it's very, you can do it. The other one was when something doesn't work, you don't give up. It's not like, okay, let me do something else and write a different paper. You have to always ask why it does work, why it does not work. If the results are too good or the results are really lousy, maybe something's not working. And so there's no answer in the back of the book. We tear things apart. We look at it from all different angles. It's not one algorithm, one paper, FDA. It doesn't work like that. I think, it takes a while to get that FDA recipe down, but I think we finally got it. I mean, everything's a learning, and it comes back to type of cases. You have to span the malignant, span the benign, span the readers even. They have to span all types. And I guess next to getting cases, the second big thing is funding. I wish there was a lot more funding. We can do a lot more, but we need. So everyone write a letter to NIH.
Maryellen, one question. So you have de novo clearance for that system as Class 2 510K. So that seems a really helpful predicate to systems coming out now. Can you comment a bit on where that places the bar for systems that reference yours as a predicate?
Yes. Okay, so just to remind folks, computer-aided detection, finding something in the screening mammogram, that was from the mid-'80s to early '90s. That was transferred to R2 Technologies, who got FDA clearance and then bought by Hologic. Other companies like iCAD are out there. That was Class 3. So when we were doing computer-aided diagnosis, we worked with the FDA, and they suggested to go for a de novo, which is first of kind. What that does is it kind of sets the recipe for others who want to go and get that. And there's been, that's why I put in that KOIOIS, or something like that, their ultrasound CAD uses context as a predicate. So we set the recipe and set what you need to do, pretty straightforward. For other computer-aided diagnosis methods, it was a high bar for us because we had to make sure, we did a reader study. It wasn't just performance of computer, but performance of radiologists with and without. I think the bar is high now, even though the recipe is there, in that you have to really show that radiologists will improve and they won't cause harm. So that's the high bar, but it's doable. I guess I don't give up, so things just happen. Does that answer your question?
It does. One last question.
Yes. Hello. My question is, how do you evaluate the performance of both your system and the radiologists? What is the ground truth in your model?
What is the ground truth for a reader study?
Yes.
Well, when you design the study, you know the truth. It's very easy to blind a computer. Can't do that with radiologists, but you can do it with computers. And you know the truth of these lesions, and you have to collect them. And you might have biopsy. Now, biopsy, we're assumed is 100% correct, though it's not. but that will tell you some, but that's not all, because in real life, you will have cases that are benign and deemed benign based on follow-up. There was something there, and they followed the woman for 2 years and it stayed. So that's another way you have truth. So the truth is the actual clinical truth that's been vetted by either biopsy or long-term follow-up.
Maryellen, thank you again so much for this keynote. You really set the stage for us.